So since then, the world has been in conflict. But there are major wars which you can recall in history. We have the First World War, the Second World War. Now, it was noted in these wars that there are people who survived after very severe injuries. And there are those who survived after minor injuries, and vice versa. But all these have been used to study responses and mechanisms of survival in trauma. A lot of studies were done in the Falklands War when Argentina was fighting with the United Kingdom. That is not very far many years ago. And you may remember the Gulf Wars, the first Gulf War, the second Gulf War. We have had the wars in Afghanistan, you've had the wars in the Middle East. And through all these conflicts, a lot of studies are being done because they are real life scenarios where the teams on the ground have to make sure that the injured survive. But despite all this, there was no clear guideline on how to attend to trauma patients until 1978, when Dr. James, an orthopedic surgeon, was flying a small plane in the US, I think in the state of Nebraska, and then this plane crashed. He was in that plane with his wife and 3 children. The wife died instantly, and the children survived with injuries. It was in the woods, so in the forest, you would say, and then he had to maneuver his way to the road, the highway, stop a car which was moving by and leading him to another hospital where assistance was actually minimal. And this is when Dr. James, with his colleague, after looking at the story and survival, said that we need to do something about improving care for the injured. And this is the real initiation of beginning the Advanced Trauma and Life Support program. Definitely 1978, 1980, the first course on ATLS was given in the US, and 1980 to today, 2024, many editions of advanced trauma and life support have been developed, which are used for training. And definitely in centers where these have been used have enabled improved survival for people who are injured. And definitely injury, when we talk about injury or trauma, it is a complex mechanism. As you can imagine, it is a complex mechanism. You have a chance to see some of the things outside: cut wounds, crushed bones, and fractures. But if you look at the body in totality, injury is a complex mechanism. And as the presenter mentioned, and the first diagrams that he gave us were basically about the road traffic crashes, which we see commonly. And most of the applications for ATLS are with road traffic accidents. That is the biggest percentage. But definitely there are other conditions that demand ATLS. For example, people who are involved in who get burns or fire. You've heard of these massive fires at events or in markets, or a fire catching a building and hundreds of people are burnt. People who fall for different reasons. We've talked about war. People who are poisoned for certain circumstances, and also people who, commit suicide for one reason or another. But definitely there are many more cases. So when the presenter talked about the epidemiology of trauma and its outcomes, would like to expand this information by saying that ATLS is applied far beyond road traffic crashes. But any patients that have experience of what we describe as trauma, body injury, or qualify to benefit from advanced trauma and life support. Definitely in most centers where developed centers like in the emergencies, the principle of caring for emergency patients, irrespective of the cause, is advanced trauma and life support. And the triage systems that the presenters talked about, you can actually see it in our emergency, that patients are not triaged because they are bleeding, but patients are triaged because of the vital signs. So irrespective of whether you are pediatric or adult, whether you are obstetric or surgical or medical emergency, your risk parameters determine the color of your bed in the emergency. So that's why ATLS has moved from basically focusing on trauma patients to advanced care in other medical fields. But for us as surgeons, we stick within the concept of trauma because of the items we have talked about, be it burns, be it falls, be it cases of war because of shooting or other forms of injuries, they will come to us. So we limit our approach to trauma with that in mind. So the applications of trauma of ATLS, as the presenter has told us, using the primary survey and then the secondary survey. And also the new approach with the C. But as I've said, that these are innovations that have come out because of the trauma, scenarios of trauma worldwide. That's how these modifications have come to be introduced for better management of patients. For example, if patients are exsanguinating, it is out of a physiological response that you stop the exsanguination immediately. That's why that change has occurred. But also something that we need to mention, it is the multi-system approach of the applications for advanced trauma and life systems. ATLS was developed in the initial concepts and the way it has been taught in many situations in Africa, that people imagine that you are alone in the emergency. You are the only doctor there who knows what to do. You are the only nurse or clinician who knows what to do. But today, ATLS, more so in the centers where it is applied, in the centers where they have these emergency teams, they are teams that are responsible for ATLS. So it makes interventions easier and easier to apply, and also to work with the different experts. Like if you need intubation, you need to set up an IV line, you need to do a venous cut down, you need sonography, you need CT scans urgently, you need x-rays. So this is the essence of the teams that support the ATLS principles. So the principles of primary survey and secondary survey are definitely, as the presenter mentioned them, but as postgraduates, there are issues that you need to look into. For example, how many patients on average would present with compromised airway saturation? How many patients on average would present with a compromised saturation? How many patients, for example, would present with multi-system injuries? So for you as SHOs, this is how you need to broaden your understanding and application of ATLS. It gives you an anticipation and planning on how you can manage your patients. It will vary center by center. The presentation of patients, for example, at Mubende, may not be the same presentation of patients in a general hospital somewhere or in a health center for somewhere. So as an SHO, you have to look at yourself as first of all, as a team leader, but also the expert in management and research. So you have to determine your local situation and be able to apply the right resources and interventions to your situation. That's why the presenter talked about capability. That one of the things, as we talk about, as we do the ATLS assessment, we want to assess the patient condition, we stabilize the patient, but also we determine the capability for us to manage this patient after stabilization. Can I retain this patient in Mubende? Can I transfer this patient to another center where they are experts? But this is something that you decide depending on your local situation. So formerly, it was mandatory that when patients came in an emergency situation, the first principles of ATLS recommended that these patients have to get oxygen support, that the patients had to get 50% dextrose, that the patients had to get a fluid load, irrespective of the parameters. But these were based on the assumption that if a patient has got has got trauma, the hypermetabolic states result into hypoglycemia. And hypoglycemia results into lactic acidosis. It was also presumed that patients who have had trauma easily go into hypoxemia because of tissue injury. And it was also presumed that it is important to assume a hypotensive state for the patient because there were limited mechanisms of investigating the patients. You are alone in the field, you have a patient who is injured, so it's better to assume a hypovolemic state than to assume a normovolemic state. So in that way, these recommendations were based on the circumstances, but today recommendations have changed. And that's where, as SHOs, you have to look at the systematic reviews which have assessed the need for supplemental oxygen in trauma patients, the need for dextrose infusions in trauma patients, and the need for fluid resuscitation and support in trauma patients. That's why the presenters told us to read about the classifications of shock. Why? Because shock is divided. There are classes of shock, class 1 to 4. And each class has certain percentages of fluid loss. Class 1 has up to 15% of blood loss, and class 4 has close to 40%, more than 40% of fluid loss, of blood loss. Now, if you read further into this, you are going to see the corresponding pulse, blood pressure, and other parameters, which will help you to know that this patient, even if I've not measured the blood loss, maybe patient has been brought from the field, but because of these parameters, the levels of the blood pressure, the levels of the pulse, the amount of urine output, I can classify this patient as a patient with a class 4 shock. So this is what is important, that you look at it and you also apply it for your patient classification, because it will determine when you are going to give fluids, the amount of fluids, and when you need to give IV fluids with blood transfusion. But the essence is that if you overload the patients, the new studies show that if you overload these patients with IV fluids, then the outcomes are not good. So that's why it is important to classify the shock classify the severity of loss so that you replace what the patient has lost. Extra additions of fluids are not helpful. For the oxygen supply, we now rely on the pulse oximeters, and we tend to at least maintain a range of between 94 to 100% saturation. Administration of oxygen has to be controlled and it has to be monitored because it can be disastrous at times. That's why it is very important to monitor, and you give the oxygen depending on the need of the patient. Then preventing hypothermia is key, as the presenter mentioned, that it is very, very important to prevent hypothermia in these patients. You may have learned already in the metabolic response to trauma. Actually, these topics are sort of related, but it is very important that you prevent hypothermia in patients who have undergone trauma. And all these mechanisms, all these interventions that you are doing, the fluid resuscitation, the support with energy requirements, giving them glucose, the support with oxygen, all these are intended to reverse the metabolic response to trauma. So, and these are the direct applications that you are going to be practicing every day in the emergency. And this is what is being done even right now for patients that have come in with trauma. But the guidance from our tutorial today is that we need to have reason, we need to have evidence, and we need to have a guideline that guides us on what to do. You need to be acquainted with the capacity to perform the focused abdominal sonography for trauma. I think as SHOs, maybe you'll have a chance to undergo this course. It is basically intended to show you free fluid in the abdomen. You have to scan using an ultrasound, look at the pouch of Douglas, and you look at the Morrison's pouch, and you also look at the paracolic gutters to determine if there is free fluid in the abdomen. You also use the scan to determine if there is a hemothorax or fluid in the pleural cavity. You can do this using a scan. The performance of X-rays, pelvic X-rays, and CT scans, that is left for the experts. You only need to know that in case you anticipate pelvic fractures, you anticipate long rib fractures, you anticipate gut perforation, you anticipate rib fractures and hemothorax, then that is when you need to perform the X-rays. Now, in advanced centers, as the presenter told us, that the recommendation is a full body CT because it can do everything for you at once in one stage. In our center, we are not yet at that level, and that's why we take case by case. And even then, we still have limitations. So we do case by case. Who needs an ultrasound gets an ultrasound. Who needs an X-ray gets an X-ray. Who needs a CT gets a CT. And even then, we are still doing brain CTs because of technicalities and other other challenges. In all these patients who have had trauma, as we mentioned in the start, is that it is a complex mechanism and it evolves. For example, patients who have had burns, if a patient gets acid burns, the burns are penetrative, they are continuous, they keep burning deeper into the tissues. A patient who has had a head injury may not present with features of an epidural or cerebral hematoma, but within an hour or so, the features will be manifested. So it is important that patients undergo the primary survey, as we've said. Patients undergo the secondary survey, as we have said, and patients go under continuous reassessment. That's extremely important. And different centers have their guidelines. But you need to know that patients should go undergo continuous assessment until you are sure that all the injuries have been identified. Just an addition to the question that Abubakar asked, if you perform a jaw thrust according to the way it is done, it is actually good because it doesn't interfere with manipulations of the cervical spine. That is one of its good things. So it is a safe approach in patients with cervical spine injury. And then the Lemon classification, that is extremely important for difficult intubations. You can read about it, and you can also speak to the anesthesia teams who can take you through more about the Lemon classification. So thank you very much. We would have spoken a bit more, but it is getting rather late. I know we shall be still interacting about this topic. So I thank you very much, and we call it a day. We shall meet again tomorrow for our tutorial at 8. Thank you very much.
Thank you very much, Doctor. We wish you a nice day.